Hello, welcome to Wellness and Wisdom. Thanks for coming back. And guess what? I have a treat for you today, especially if you've ever wondered about if you can take hormone replacement after having had breast cancer or after having been told that you have the gene that increases your risk for breast cancer. So I'm not going to preempt the whole podcast. You have to listen to it. I'm talking to Dr. Avram Blooming. He is great. So come on, let's get started. Today, I'm talking with Dr. Avram Blooming about breast cancer. Dr. Blooming is an oncologist. Yes, that's right, a cancer doctor. And today, we're going to find out why he believes that women who have had breast cancer or a family history of it can safely take estrogen therapy. Dr. Avram Blooming received his BA and medical degree from Columbia University. He was an investigator to the National Cancer Institute and has taught at various medical and academic institutions, including two of my alma maters, Harvard and Johns Hopkins, along with Princeton, his own alma mater, Columbia. He is currently an emeritus clinical professor of medicine at the University of Southern California. In addition to being on my podcast, he has been profiled in the Los Angeles Times and the Lancet, which is the leading medical journal in the UK, and many, many other publications. He organized the first study of lumpectomy for the treatment of breast cancer in 1978. Lumpectomy means you remove the lump as opposed to taking the whole breast. For over 3 decades, he has been studying and publishing the benefits and risks of hormone replacement administered to women with previous history of breast cancer. In 2018, he wrote a book entitled Estrogen Matters: Why Taking Hormones in Menopause Can Improve Women's Well-Being and Lengthen Their Lives Without Raising Their Risk of Breast Cancer. Since its first printing in 2018, it has ranked by sales in the top 1% of all books on Amazon. The second edition just came out this week. Talk about cutting edge. His most recent publication is called Hormone Replacement After Breast Cancer. It is time. This review article was published in the Cancer Journal, volume 28, number 3, in the summer of 2022. I will put the references for 3 of his articles in the box below. Believe me, they all make very interesting reading. I'm more than excited and honored to say hello to Dr. Blooming. Thank you so much for coming in. We have so much to talk about.
Nadu, I'm delighted to be here. Let me just make 3 edits. The first is you said I introduced lumpectomy. Actually, it was introduced in the medical literature in 1929 by Joseph Hirsch, but I did introduce it, the study of it, in Southern California. Second, you did mention the book, and it's important to say that my co-author in Estrogen Matters is Carol Tavares. Carol is a PhD social psychologist, and she is the soul of the book. If you listen to the audio book, you get a sense of who Carol is. If you read it, you see that she's got a mischievous sense of humor, but an allegiance to data that is as profound as mine, or more than that. And finally, the second edition of the book is actually going to be released in September of 2024.
I thought it was out this week.
No, but it is a pleasure to join you.
Okay.
Yes.
Well, thank you for those edits. We love to be accurate. So in my experience, breast cancer is the biggest fear that women have when they think about taking hormone replacement. Hopefully today we can allay some of those fears. So first, let's talk about breast cancer, the elephant in the room. Unfortunately, the incidence of breast cancer has been steadily rising over the past 2 decades. Do we know why that is?
The short answer is no. A longer answer is we started doing mammograms for a larger and larger population. And while ductal carcinoma in situ, which, as you know, is the earliest form of breast cancer, even before it becomes invasive, constituted only 3 or 4% of breast cancers that were diagnosed before we were doing all those mammograms, it now constitutes between 25 and 30%. And so a large part of that increase may in fact be due to better diagnostic ability. In addition, medicine is improving and people are living longer and longer. And as you know, the biggest risk for the development of breast cancer after gender is age. The older you are, the more likely you are to develop breast cancer. And we just ought to mention that currently early, newly diagnosed breast cancer has a cure rate of over 95%. And that's not meant to minimize breast cancer. As a medical oncologist, I've been dealing and fighting with breast cancer for decades, but a cure rate of better than 95% at least allows us to smile the way you are smiling now on my screen.
The reason I'm smiling is because that was my next question. What is the success rate of breast cancer? So you preempted it. You could see it coming. So premenopausal and perimenopausal women used to be sterilized and or advised to have abortion if they were breast cancer survivors. Do you think that perhaps the medical community is a little more enlightened now?
Well, we are learning more and more. It is eminently reasonable, not accurate, but reasonable to say that the incidence of breast cancer is 100 times more frequent among women than it is among men. Yes, men get breast cancer, but at a much reduced rate compared to women. And so a likely hypothesis is that estrogen is somehow responsible for the development of breast cancer. And we haven't completely eliminated that hypothesis because we still don't know what breast cancer is and what causes breast cancer. But the treatments that you just spoke about that were based upon the assumption that estrogen is bad and must be removed from a woman's system if she is either at risk of developing breast cancer or worse, has developed breast cancer, have now been disproven by extensive studies. So that, for example, I used to advise women who were diagnosed with breast cancer while they are pregnant to have an abortion because, as you know, pregnancy dramatically
Floods
increases
with
the
estrogen.
level of circulating estrogen in a woman's body. And so my patients would have abortions if they were diagnosed with breast cancer in an attempt to improve their cure rate. We now know with extensive studies that abortion not only does not improve the prognosis of newly diagnosed breast cancer patients, it might even worsen the prognosis.
So, if estrogen is solely to blame for breast cancer, why do men get breast cancer?
Well, men have circulating estrogen levels too, but the answer is estrogen is probably not to blame. That is a hypothesis, but the data don't seem to support that hypothesis. In addition, there are complicating issues here so that we can measure circulating estrogen. It is difficult to measure tissue estrogen and local tissue. In fact, many tissues in the body produce estrogen, not just the ovaries or the testicles.
So, three of the fascinating articles that you've written about estrogen in women with breast cancer, I'm going to put the references in the box below. But before we get to those, your book is called Estrogen Matters, which I find very intriguing because most oncologists are not usually proponents of estrogen or hormone replacement therapy. So, can you tell us why you named your book Estrogen Matters or co
Sure.
authored the book?
The first title for the book was Who Killed HRT? Because, in fact, in the 90s, up to 44% of postmenopausal women in the United States were taking hormone replacement therapy. And after the Women's Health Initiative was first publicized by press conference and then by a published medical article, that number of 44% dropped to less than 5% of eligible postmenopausal women, and it stays at that low level even today. So Who Killed HRT sounded like a good title.
It sounds good to me.
Well, and in fact, the first chapter was called killed HRT. But we had a meeting with Little Brown, our publishers, and our agent, Gail Ross, and we try to come up with a better title that was easier to remember. And Gail Ross, our agent, finally said, why don't you just call it Estrogen Matters? And that sounded good to all of us. And that's why it was named Estrogen Matters.
Consensus. So I would like to talk a little bit about what specifically got you interested in the subject of hormone replacement as an oncologist. Why did you become so interested in estrogen?
Well, about 60% of my oncology practice was made up of women with diagnosed breast cancer. I treated all cancers, but breast cancer was clearly the one I saw most often. And as we got better and better at treatment, I was responsible for inducing significant symptoms among many of my patients. Tamoxifen was introduced in 1979, a drug that appears to help women with diagnosed breast cancer, cancers that are estrogen receptor positive. Chemotherapy was introduced. Chemotherapy among perimenopausal women frequently induces menopause. And women would say to me, I feel terrible. I can't sleep. I have anxiety. I can't think clearly, and I'm an academician, or whatever I do, I can't do it as well as I used to. I have no desire for sex any longer. And in fact, if I allow my partner to have sex with me, it's painful. And my answer was as sympathetic as I could make it. Mm-hmm. But the bottom line was, suck it up. You had breast cancer. I didn't say it that way, Nadu, but what I was really saying is I can't really help you. And I treated the breast cancer, and you have an excellent chance of being cured of the breast cancer. So deal with it. It doesn't last that long, and it can't be that bad. Turns out it does last that long and longer. The median duration of menopausal symptoms runs about 7.5 years. For women of color, it runs a median of about 10 years. 80% of women through perimenopause and menopause are significantly affected by these symptoms, and there is a treatment for it. And the treatment is estrogen. Nothing else comes close. Estrogen is capable of ameliorating or eliminating the symptoms in close to 90% of patients. And the symptoms aren't just hot flushes and night sweats, which is what we hear about.
Right.
The symptoms are palpitations, brain fog, painful urination, frequent urinary tract infections, GI symptoms. There are many, many symptoms. In our book, we list 32 symptoms of menopause. And so it was much more of a problem than I gave it credit for being. And then at age 45, my wife was diagnosed with breast cancer. And I treated her with chemotherapy. I induced premature menopause in my wife. She had many of the symptoms we've gone over, and she didn't complain about any of them. Not to me, not to her gynecologist, until she found that when she was reading a book, and she is a voracious reader, she would find that if she tried to remember what she read 2 or 3 pages back, she couldn't. When she listened to music that she knew, she couldn't remember what she had heard. And that was devastating. And because of a combination of my increased understanding of menopause and my obvious concern for my partner in life, I became very involved in trying to understand as best I could and trying to develop approaches for it.
So a friend of mine says, one of my colleagues, she said something to me one time, which I love repeating. She said, a hot flash never killed anybody. But the other symptoms of estrogen, The long-term benefits are not discussed. Everyone thinks about the hot flashes. So clearly, there are so many benefits to estrogen, long-term heart disease, bones, and so on. So what, in your view, are some of those benefits? You said you listed them in your book, and hopefully everyone's going to go buy the book right now. But what do you think are like the big ones?
Let's talk about nomenclature for just a minute. Hot flash was probably a description coined by a man, not by a woman. A flash, if you think of a flashbulb, lasts for a fraction of a second and it's gone. If you think about a discomfort that starts in the middle of your head and the middle of your chest and then spreads out onto your chest and onto your face, which then turns red and is covered with sweat and lasts about 10 or 15 minutes, that's a hot flush. And having several of those a day impedes any productive work. So that's one symptom that is worth concentrating on. Hot flushes will be relieved with estrogen in as close to 100% of patients, and it's never 100%.
I must say, you are a good spouse and a good listener, and I can see you're a good partner because that description obviously came from someone who experienced it. Yes, I'm sorry to interrupt you. Go ahead.
That's quite all right. The night sweats, which are a corollary of hot flushes and may in fact be a nighttime manifestation of a similar process where a furnace starts going on inside you, are also relieved so that your sleep improves, you're able to sleep better, you awake refreshed and ready to start the next day. Palpitations can be worrisome. As far as I'm aware, the kind of palpitations you feel where your heart is either racing or irregular are not dangerous if they are due to hormone deficiency, but they're worrisome. And my wife had them, and we went to cardiologists who reassured her after extensive testing
Full workup.
that her heart was fine, but that didn't treat the
Didn't
rapid
help to get
pulse.
rid of them.
Right. And with additional reading, I found out that that is a common manifestation of menopausal symptoms. And even today, most cardiologists do not recognize that it's a symptom of hormone deficiency. The symptoms related to the genitourinary tract, where you have burning on urination or you have some incontinence or dry vaginal mucous membranes that make sex unattractive or impossible. Frequent infections can lead to kidney disease. Those can be treated with vaginal estrogen. And interestingly, many physicians feel that vaginal estrogen must be avoided, especially in women with a history of breast cancer. And the overwhelming data in the medical literature say it's fine. You can take vaginal estrogen. If you look carefully at the data, even for systemic hormone replacement therapy, I've written the book to show this, but also other articles, that also appears to be good. But anybody who, good meaning safe, but anybody who tells you we have the absolute final answer is trying to sell you something that you shouldn't buy or is simply lying.
So, is it true that estrogen increases longevity? And
Yes.
if so, why?
We have to talk about the Women's Health Initiative. The Women's
Oh,
Health Initiative
the
was,
ghost lives on.
yes, well, interestingly, Bernadine Healy was the first, so far only one of two women to lead the National Institutes of Health. And Bernadine Healy was a cardiologist. And what she said rightly is, it's funny, most of the medical studies that the NIH supports are done on men, not on women. And that doesn't have to be misogyny. If you read the articles about that, what researchers would say is, well, women have the ability to get pregnant. And if we're looking at new drugs or new procedures and we inadvertently include a woman and give her the drug or the test, maybe we will hurt the pregnancy. So it's safer to do it on men because at least so far, men haven't been found to get pregnant. But what she found is even the animal studies that the NIH supports are done on male animals. Even the cell lines that are studied are male cells. And she said, that's bizarre and inappropriate. And she wanted to do a study directed at women to see if women would benefit from that kind of a study. And the result was a $600 million grant to investigators who were leading investigators throughout the United States. And they were to study whether hormones really helped prevent heart disease. Bernadine Healy was a cardiologist. She said that heart disease is and still is the number one killer in women. And let's see if hormones will improve a woman's prognosis so that she wouldn't develop heart disease and improve longevity. And the study was designed to treat primarily older women. The median age of the women entered into the study was 63. As you know, menopause usually starts between 49 and 51, and 63 is significantly older women, but this was already an expensive study. And if you're looking at heart disease, since heart disease is more common among older women than among younger women, especially atherosclerotic heart disease, it will be a shorter study if we do it on older women. And that's a reason to choose older women. And the result that was first publicized, and I keep on stressing this, by press release. Usually, as you well know, most studies are first published in medical journals, and that gives doctors a chance to review them, and then they're written up in the lay press. But the WHI investigators wanted to make a big splash, and so they had a press conference, and at the press conference, they stated they are prematurely stopping this study, at least the estrogen and progestin arm of the study, because they were finding an increased risk of bad things happening. What were the bad things? Well, for one thing, the women were having an increased, not a decreased risk of heart disease. For another, they were having an increased risk of cognitive decline. They also had a small increased risk of stroke. And they said this in the press conference, and they wrote this in the article, they said there's an increased risk of breast cancer. Never mind that increased risk of breast cancer was not statistically significant. It was in the press conference. It was in the article. You had to read the fine print in order to know it wasn't statistically significant. The New York Times headline was, "Hormones increase the risk of breast cancer. Women flushed their hormones down the toilet. Doctors refused to give any more hormones." Right.
And that's what sticks in people's minds.
Yes,
that
it does.
whole breast cancer thing.
So what do we know about that today? Well, there were two arms to the study. One arm was women who were given estrogen and progesterone together. And as you know, estrogen is really the main drug used for either what you call hormone replacement therapy or menopausal hormone therapy. But estrogen alone increases the risk of uterine cancer. And so it was found that if you give progesterone with estrogen, you nullify that increased risk of uterine cancer. And so women who still have a uterus are given estrogen and progesterone, while women who have had a hysterectomy get estrogen alone.
Sometimes.
And what we now know from the Women's Health Initiative is estrogen alone, not only does not increase the risk of breast cancer, it reduces the risk of breast cancer by 24% in the Women's Health Initiative study, and it reduces the risk of death from breast cancer by 40%. Never mind that many people still say estrogen causes breast cancer. That doesn't
Yeah.
seem to be borne out. If you buy any product containing estrogen, there is a black box warning on it that warns you that it causes several diseases, including breast cancer.
Breast cancer.
That black box warning was put in 6 months after that press release. It should be removed. It has still not been removed.
22 years later.
Yes, the combination of estrogen, and by the way, I said that the median age of women who were tested was 63%, so relatively few were perimenopausal or menopausal. And if you look at women who are within 10 years of their last menstrual period on the Women's Health Initiative study, what we find is they don't have an increased risk of heart disease. They have a decreased risk of heart disease by up to 50%. They don't have an increased risk of cognitive decline or Alzheimer's disease. That, in fact, although the Women's Health Initiative still hasn't found a decreased risk of Alzheimer's disease, there is no increased risk of cognitive decline. And in that study, only women who already were suffering from cognitive decline had what they called cognitive decline. They don't have an increased risk of stroke. In fact, every damaging conclusion of the Women's Health Initiative has been reversed by the Women's Health Initiative investigators. And they've written reports about that, but they haven't held another press conference. And most people, including physicians, don't understand that. There is one conclusion of the Women's Health Initiative that they still hold on to. And I've written, and you have the reference to them, articles attacking that one conclusion. What they still say is the combination of estrogen and progesterone in their study increased the risk of breast cancer. Didn't increase the risk of death from breast cancer, but increased the risk of breast cancer. And that conclusion is demonstrably wrong looking at their own data. We can discuss that. I'm afraid of getting too technical. It's clearly explained in the articles and in the book.
Yes, so coming back to the articles, I see you've been very busy over the past few years, Dr. Blooming. I've read the 3 articles that I mentioned earlier, and you also obviously put out the book. That's a lot of work. What made you so motivated? Was it your wife?
Well, my wife had a role in my getting interested in the field, but the joy in medicine is twofold. The first is taking care of patients, especially as a medical oncologist, Nadu. Any person walks into my office, within 5 minutes, we have an intimate relationship. I can't think of another profession where that is possible. You can't lie to each other. I can't lie to the patient. The patient shouldn't lie to me. And you develop a respect and an affection for people that socially you would never meet. And I love that part of the job. The second part of the job is there is so much we don't know. And the joy, which I've seen in my 50 plus years of medicine, is finding something that used to be terrible that we can now eliminate.
Right.
And the answer to your question is if I find a clue that would allow me to help the people under my care, and by extension, many other people as well, I follow it with a dogged persistence. It is among the most exciting things I can think of to do.
Well said. I must say that I get excited too when I discover something that is beneficial to so many people, and yet I get a little frustrated when the information is not out there and people are not being informed or educated about these pieces of information that really could be life-changing.
Absolutely.
So I think let's turn to HRT. Let's circle back about and talk about estrogen replacement, specifically after breast cancer. I think this is a crucial topic because some unfortunate women get breast cancer in their 40s, and assuming they have a normal life expectancy, they may have another 40 years to go. And for them to have to live 40 years without the benefit of hormone supplementation, which we already talked about all the benefits, and there are still women who are being denied hormone therapy, even if they have, for example, BRCA, and they have an oophorectomy, they have the ovaries out, the breast cut off, still the doctors won't give them the hormone replacement. So, what do you think about that? I mean, you can't give a broad brush. Everybody can have everything, right? Obviously, it's customized. But at the same time, there are a lot of women who may qualify and benefit from hormone replacement who are still being denied it because of their family history or their own personal history.
Correct. And the job of physicians is to stay up to date. I said that there is a joy in being able to change a prognosis because of things that we are learning, and we are learning things all the
Every
time.
day, every day.
So that, for example, we know that if you remove the ovaries of a premenopausal woman who has one of the deleterious BRCA gene mutations, you reduce her risk of developing breast cancer by 40, 50, maybe even 60%. Well, that sounds like a cut and dry situation. Remove the ovaries and she may still get breast cancer, but at a greatly reduced risk. But there are now studies that have been done showing that if you give estrogen to these women
Ooh.
who had their ovaries removed, you do not change that dramatic reduction in the risk of developing breast cancer. Can I explain that? Not completely, but it certainly takes the onus off of estrogen, which you've removed by removing the ovaries, but then replaced with estrogen replacement, and they still seem to be fine. You have not restored their increased risk. In addition, we used to tell women who had breast cancer, especially women who had estrogen receptor positive breast cancer, which just means that their breast tumor cells have an identified receptor on their membrane. We used to tell them you must never get pregnant because estrogen is bad. And pregnancy dramatically raises the level of estrogen in your body. Well, there are now studies that have been done showing that pregnancy has no negative effect on women who were breast cancer survivors, even those who had estrogen receptor positive breast cancer. And in fact, it seems to improve the prognosis. And there are studies in many different institutions around the world supporting that. There is a study that came out in 2023 out of Mass General where women with estrogen receptor positive breast cancer who were young and wanted to have children and were on tamoxifen were told, you can join the study. We will stop the tamoxifen that you are getting to help prevent recurrence and allow you to get pregnant so that you are off tamoxifen for 3 years. And many, many women were looked at, and pregnancy, stopping the tamoxifen and pregnancy had no negative effect. It did not increase the risk of breast cancer coming back. And so physicians who say estrogen is poison, it causes breast cancer, you must get off estrogen and never take it again, are clearly not working from available data. The article that I sent to you that you have reference to is called Hormone Replacement After Breast Cancer. It is
It's
time.
time.
And that doesn't mean that I know for certain that it's 100% safe. I know very few things with absolute certainty. Part of science is that we are constantly learning, but we learn from increasing data availability and intelligent analysis. And there are now 26 studies in the medical literature that look at what happens to breast cancer survivors who take hormone replacement therapy after completion of their treatment. And of the 26 studies, 25 studies found no increased risk of recurrence. There are 26 studies in the medical literature that I reviewed and published the review in 2023. Of the 26, 25 found no increased risk of breast cancer recurrence among women who started taking hormone replacement therapy. In the article, there were actually 25, and in the book now there was another study, so it's 26. But of the 26, only one showed an increased risk of recurrence. And this, 4 of the studies showed a reduced risk of recurrence if they took hormones. The one study that showed an increased risk is called the HABITS study, and it came out of Sweden. HABITS is an acronym for Hormones After Breast Cancer. Is it safe? What they found is a small increased risk of local recurrence, not of distant recurrence, and not of death from breast cancer. The small increased risk was seen in this population of women who didn't have baseline mammograms when they entered the study. Well, wait a minute. If the only recurrence is local, isn't it important to know if there was something in the breast before they were placed on hormones? And because mammograms or some breast visualization study was not mandated, you can't answer that question. There was another
Right.
study done in Stockholm, Sweden at the same time called the Stockholm study, which didn't find an increased risk of recurrence. So that one study out of 26 is clearly challengeable. And the other 25 studies found no increased risk of recurrence. I think it is reasonable based on that to discuss those results with women and allow
Correct.
women, together with their physicians, to decide whether this is something they would like to do. And if they say yes, I think it is equally important that we continue to collect data so
Yes.
that physicians should have women sign an informed consent, agree on a uniform data program so that we could learn as we are doing this, so that if we have this discussion 10 years from now, we would be even more certain of our conclusions.
You seem to be going against the grain of most oncologists. I will mention that. But I think that that's because, like you said, people are not staying up on the data, staying up on the information. We physicians tend to be stuck in a particular rut and ditch, and we just don't want to make changes. What we were taught 20, 30 years ago, we just feel like, well, that's it. But of course, as you pointed out earlier, so many people's lives are affected by the idea that breast cancer means no hormones, and it's just a dead stop right there.
When you introduced me, you said that I introduced or was part of a team that introduced lumpectomy in the treatment of breast cancer to Southern California. Talk about going against the grain. I came to Southern California from Boston, and shortly after I came here, I decided to start that study of lumpectomy as lumpectomy radiotherapy as an alternative to mastectomy for the treatment of breast cancer. I grew up on the East Coast. I had no referral contacts here in Southern California, and I was advised by friendly doctors that I would be crazy to start this kind of study. He said, "You're a medical oncologist. A large part of your referrals are going to come from surgeons, and you're going to tell surgeons that they should do lumpectomy instead of mastectomy. You're not going to be here long." Well, that was 1975. And what I found, and I gave talks in hospitals, I became the chairman of the education program for the American Cancer Society, which was the second largest branch of that organization in the United States. And what surgeons found is once they did a lumpectomy for whatever reason, and they told me this, The gratitude of the women was so overwhelming that they never went back to mastectomy unless there was no option in unusual situations. And we published the results of that study, which was a community based study looking at lumpectomy compared to what we knew about mastectomy cure rates. And we found that the cure rate was equal, and it helped change the treatment of breast cancer both here and around the world.
Does it matter what kind of breast cancer a woman has, whether or not you would recommend they consider post treatment estrogen?
As far as we know, the most important differential, which you would think would matter, meaning do they have a hormone receptor positive tumor, estrogen and or progesterone receptor positive, the answer based on the 26 studies so far is no. What about other kinds of cancer? What about ductal carcinoma in situ? What about inflammatory or triple negative breast cancer? Thus far, we need more information, which is why I say, wouldn't it be wonderful if we collected information as we treated patients? So far, the answer is no. It doesn't seem to matter.
Do you think that estrogen is anti-inflammatory?
Up until this point, you've noticed I referred to data to make a statement. So
Mm-hmm.
that when you use words like, do you think or do you believe, my answer is, I don't know. I can look to see whether it's been anti-inflammatory, but I don't know. And I'd rather say I don't know than give you an opinion that I can't on the spot support with information that has been verified.
That's fair enough. I've heard people refer to it as anti-inflammatory, so that's why I was asking you, because I wondered if that had something to do with
Fair
the
enough.
benefits post breast cancer.
Mm-hmm.
Now, you had mentioned that you had family members who had breast cancer. Would you give them HRT?
Well, the answer is my wife was on HRT for 28 years. My daughter, now she was actually in her mid 30s, developed breast cancer.
Very early.
She then wanted a child. She was happily married, but was having difficulty getting pregnant. And so the question was, should she undertake in vitro fertilization? That's a hard question because, as you know, that's associated with significant hormone administration. There wasn't a great deal of data on that. There now is. And the result now is it doesn't appear to harm the prognosis. And she did it. And my granddaughter, who is now a healthy, happy teenager, is a joy. And then my daughter developed estrogen receptor positive breast cancer. And her mother, who had developed it at 45, my daughter developed it at 35. My daughter asked me about hormones. And I told her, I'm not sure. I gave her the information. This was quite a few years ago, but I gave her the information that we had. And I wrote about this in the book with her permission. And she said to me, I don't understand. Up until this point, I've asked you for medical advice my entire life, and you've always told me what you thought. And you're not telling me what to do this time. And I told her that the truth is, I don't have an absolute answer, that I think it's safe, which is why I've been running this study on patients all these years. But without knowing for sure, I can't tell her what the right course of action would be. And I would hate to tell her this is what you should do, and God forbid, have her cancer come back. She decided to take the hormones. She's been on them now. She's just 54, so she's been on them for quite a while. She is doing wonderfully. That's a long winded answer to your short question about my family members.
No, that's a great answer because it shows that you too have been through not just the thought process, but the emotional,
I'm very
feelings,
aware of being on the
what's
receiving end.
what's involved, yes. How difficult it is to make a decision when you don't know 100% sure that it's the right thing to do.
Correct.
But I always tell people, look, if you want to be 100% safe, don't leave your house, don't drive your car, just lock yourself up in you can guarantee you will not have a car accident because it's not all about you. You don't know who's coming around the corner. But if you do that, you won't have a life either. So thank you so much for sharing. And if you could just emphasize for us the benefits of estrogen, and I'll let you go. I really, really, really appreciate you having you on the show today. And all your information is fabulous. But I want to make sure that people have heard the critical points, which would be how estrogen is beneficial and whether it's going to cause cancer or what the change in percentages are.
Sure. First of all, the symptoms, we spoke about the symptoms. 80% of women are affected by menopausal symptoms. They last a median of 7.4 years. Estrogen is the single best treatment. It will eliminate or dramatically improve symptoms in 90+% of women treated. Nothing else comes close. We mentioned heart disease. 7 times as many women die of heart disease in the United States as die of breast cancer. And heart disease is reduced if hormones are given within 10 years of a woman's last menstrual period. The risk of serious heart disease is reduced by 50% by estrogen. Women usually say to me when I say that is, well, heart disease kills old women and breast cancer kills young women, and I'd rather die when I'm old than when I'm young. Well, in fact, in every decade past age 40, the risk of death from heart disease is greater than the risk of death from breast cancer. Every decade past 40, and the difference increases the older you get. And estrogen reduces that risk by 50%.
Critical.
About as many women die in this country each year associated with osteoporotic hip fracture as die of breast cancer. And estrogen reduces the risk of osteoporotic hip fracture by 50%. Calcium and vitamin D in postmenopausal women who don't take estrogen has no benefit vis-a-vis the bone. The bisphosphonates drug like Zometa work for about 5 years. Estrogen works continuously. And in fact, if you take estrogen, that protection stays as long as you take it. Once you stop taking estrogen, your bones start to age so that within 5 years of stopping estrogen, your bones are as fragile as they would have been had you never taken it. Again, estrogen reduces the risk of osteoporotic hip fracture by 50%. If women are afraid of one thing more than breast cancer, it's Alzheimer's disease or cognitive decline. And there is no prospective, double-blind, randomized study of estrogen and Alzheimer's disease, and there never will be, because the definition and the diagnosis is too hard. The duration of the treatment makes it impossibly expensive. Most of the studies that have looked at this have reported decreased risk of cognitive decline by between 25 and 65% among women who take hormones compared to women who don't. And Lisa Mosconi, who's a neuroradiologist at Weill Medical Center in New York, has done estrogen PET scan studies on the brain showing that estrogen decreases the risk of brain deterioration radiologically.
Yay.
There are animal studies that support that.
That is fabulous.
And women who take estrogen hormone replacement therapy live longer than women who don't. The median improvement in longevity among women with no diagnosis of breast cancer is somewhere around 3.5 years.
That was great. Thank you so much for that summary.
It's a pleasure,
And
Nader.
I really appreciate you coming on, and thank you for being so patient with technical issues.
It's a pleasure. I'm delighted.
Thank you so much.
Take care.
You too. Thank you for joining me on another edition of Wellness and Wisdom. Today we talked to Dr. Avram Blooming. He was fabulous, and there's not much more for me to say. I think we said everything on the podcast, but I really, really, really hope that you find this on my podcast interesting and helpful. And if you know someone who's had breast cancer and is considering hormone replacement or has a lot of questions about it, please share the podcast with them. Give me a like, subscribe so you can hear when I put out new podcasts. And thank you so much for listening. So, this is Dr. Nadutuwakli. I'm signing off until the next podcast. Please be well and stay safe and keep up with the health education. It's so, so, so important. If you're not sure about something your doctor tells you, you can always do more research. You can always get a second opinion and you can live your life to the fullest. Wishing you all the best.